And we just wanted to take a little moment to discuss our breast health equity um, program, and really our sisters. Give me your hand. I'll let Evelyn, who is the co-PI, start out.
Can everyone see my screen?
Yep.
Okay, wonderful. So, so why was this project brought together? You know, we worked together, Dr. B, Dr. Hussein, and I, a few years ago, putting in a grant through Pfizer because we wanted to really address some of the disparities, some of the inequity that we saw in our communities. Dr. B had been with us in MD Anderson Cooper for a number of years and was moving to New York. And we just thought it would be a great opportunity to do a collaborative project, looking at our two communities and seeing how we could address some of the inequities that we saw based on the research and based on, you know, the interactions that we had with our patients. So we put together this project, Sister Give Me Your Hand, to address those disparities in our two cities. Why? Because when we looked at Brooklyn, New York, they had the highest breast cancer mortality rates of the boroughs, the 5 boroughs for Black women. And also, and perhaps leading to some of that higher mortality was the fact that New York had issues with backlog and long waits for mammography screenings at local hospitals. So why were women dying more? I'm sure for a number of reasons that have been brought up many times in the research and also in the literature. But you know, this backlog was probably part of the reason why we were having issues with women getting diagnosed in a timely manner. Now, when we looked at Camden, New Jersey, our screening rates were lower for mammography. And unfortunately, that also led to higher breast cancer incidence, late stage diagnosis, and mortality rates, which were higher in our city, in our county, compared to the surrounding counties, as well as to the state and the nation. And then when we looked at Black women, it was even worse. Black women's 5-year survival was worse, 80.9 versus 86.3 in Caucasian women, higher mortality rates, as well as higher late stage diagnosis. So looking at this data, we knew that we need to do something to address or to try to address some of these issues. So our grant originally was meant to involve very heavily churches in our area and trying to encourage women, Black women specifically, to get screened and to be educated about the importance of screening. We wanted to specifically work with churches in our community and get them to let us know about community persons in their churches who would be able to serve as strong advocates in educating the community. And in the beginning, when the grant began, we actually had great support. Brooklyn, New York, specifically through Cornell, had been working very strongly with some of the churches, and they had 25 churches that were interested in participating in this effort, with 11 committed churches. In Camden, we had 6 churches that became very interested and 3 that ultimately committed. When we had this in the beginning, pre-COVID, there was great buzz and great interest in being a part of the program and getting these navigators trained. But unfortunately, what happened was that as COVID became more of a widespread pandemic, we started losing the interest of the churches who were no longer able to have any interactions with their community live. And also lots of fear, and they were really dealing with a lot of issues going on with their church members. Additionally, with some of our navigators, they were losing family members to COVID. They were getting sick themselves. We tried to pivot to 100% virtual. And because a lot of these women in both our communities were older, they were having difficulties accessing some of this social media and these virtual realms that we were trying to get them to get trained in. So ultimately, we lost a lot of our clergy, although I can tell you that in New York, at the end of it all, we had 7 engaged churches and 12 engaged navigators who were able to encourage 134 women to get screened. And in Camden, we had a total of 3 navigators who were able to recruit and encourage 89 Black women to get screened. So all was not lost. What we finally wound up doing was working with focus groups, which Dr. B is going to discuss a little more, as well as virtual education and our CME, which really became a great effort to train and educate not just our physicians and our other providers, but also some of our community healthcare workers. The mobile mammography that we had wanted to really promote in our communities was stopped for quite a while with COVID. And instead, we offered extended hours during evenings and weekends. And the podcasts that we wanted to do throughout the 2 years of the grant were put on hold due to COVID, but they will be upcoming in the future. And I leave you now with Dr. B to discuss the next session.
So our successes, and I should say, I distinctly remember, Evelyn, when we had the conversation about the pivot at the peak of COVID, when New York and New Jersey were hit quite heavily, that we had to really think about now what we were concerned about, the widened gap of disparities that would now exist for breast cancer. And so we're happy to report that despite COVID, that there were a number of successes in our pivot. So last year we hosted the first breast health disparities CME program, free CME program, and it was a week-long virtual education series. I know we have a number of repeat participants, and we're so grateful that you have taken the torch in really becoming advocates to eliminate breast cancer disparities. We received excellent feedback and made some changes this year with our CME activity. We actually condensed it to 3 nights, and then have some case studies at the end of on the 3rd day, the end of the symposium. We actually added focus groups as a research project to look at actually Black women who in our communities, we wanted to better understand what their barriers would be because of COVID. We didn't want to assume, oh, this is going to be the barrier to getting a mammogram, or this would be the barrier. We wanted to hear from Black women in our communities during COVID to see what they thought the barriers were. And we learned actually a great deal. Of the women who participated, 90 had a mammogram in the past, but only 2/3 had in the past 2 years. So there was opportunity to encourage mammography screening, which we did. Breast cancer screening decisions really point to negative and positive influences, some of which we always talk about it, but I really didn't sort of put in my head discrimination and the effect that it may have on one going to get a mammogram, and mistrust in the healthcare system. We also learned about related poverty, insurance status due to loss of job, as well as issues with getting a mammogram because of breast pain. So that was our focus group. The virtual community education series is what we hosted, and we actually have our project coordinators online, Francis Antoine and Placette Wiggins, and I welcome them to join if they would like. They have really been true advocates in pushing the program forward despite COVID. So I really want to give them an applause and great kudos. And just to talk about really quick, go back to the CME program, I would be remiss if I did not mention also Nora Lee, who has just been, Nora Lee Nunez, who has just been phenomenal in helping put together our CME application, and all of the emails that you've received in regards to registering for the breast health symposium, and emails that you will receive in the future. Next slide. So our future plans, we actually will are in discussion of hosting a work group to really meet with grassroots organizations and sororities to discuss breast disparities. So we want to expand our wings a little bit. We want to improve access to screening mammography now through mobile mammography, which are now open because of some COVID lifts. And we do have a podcast in the works. And so stay tuned to that. We will be sure to update you all on when those are complete. And we are conducting surveys across our two communities to assess barriers to breast cancer screening for Black women. In addition to that, we recognize that the way that we educate our community is important. We found that out from the focus groups and from even last year, our symposium. And so we've developed animated videos for community women discussing the importance of breast cancer screening and ways of addressing discrimination in healthcare and coping with breast pain. And then finally, we are developing a collaborative website with information for physicians and patients and grassroots organizations so that they would have access to some of these videos and some of these discussion points. So again, this is a team effort. We are just blessed to be in this position to really highlight breast disparities. And this is just some flyers that we had illustrating that we increased appointment times for patients to improve access. Next slide. And that's basically it. Thank you, Evelyn. Thank you, Dr. Hussein. And then again, I have to thank Frances Antone and Placette Wiggins and Noralee Nunez for your constant support throughout this program.
Thank you, Dr. B, and thank you, Evelyn, for elaborating on Sister Give Me Your Hand initiative. For everybody, you can follow this program on Twitter and Facebook. And thank you so much again for Dr. Nguyen for this amazing lecture and our amazing strong survivors. And everybody who joined us tonight. With that, we would conclude our event this evening.
Yep. And as a reminder, please fill out the post-evaluation questionnaire, which you will receive at the conclusion of this webinar tonight. And then again, we will do it again at the conclusion of tomorrow night. Please log on tomorrow because we have an excellent lineup with the extraordinary Dr. Lisa Newman, the phenomenal Dr. McCaskill-Stevens, and expert duo, Dr. Tamimi. And again, you will see Dr. Melissa Davis. Again, thank you and have a great night.
Have a great night, everyone.